Captain Townsend, myself, and Sergeant Gonzalez. They're two ADOS soldiers. Go ahead with the next slide. Next slide. All right, on our agenda today, we're going to discuss basically the components of the line of duty. We'll talk briefly about the EMMPS module. That's the E line of duty module through MedChart. We'll also talk about responsibilities of the soldier, the UA, the unit commander, all levels in the process of line of duties. And then when to do a line of duty. I know there's a lot of questions of, should we start one now, should we start one later? At what point do we start a line of duty? We'll also discuss types of line of duties, informal, formal. And then we'll also discuss some other medical care options for the soldier that gets hurt during drill, is hospitalized, needs some other type of follow-up care. I'll be covering all those topics. Incapacitation pay, another one everybody kind of steps back from, goes right in hand with the line of duty. And then we'll discuss some other options, WTU, ADME, and finally the recovery care coordinators and what they can do to help you guys out at the unit level as well as the soldier level. Next slide, please. Here's our references. There's two drill DOTIs that take effect, and then AR 600-8-4. I would advise, after you've read Sergeant Larson's and Major Mangum's ARs, and you really want to go to sleep, look at AR 600-8-4. But it really does have some good tables. It gives you some timelines, kind of what to expect, and you can take a lot of good stuff out of that regulation. So if there's any questions, please refer to the 600-8-4. And feel free to call anyone on our team. We'll be more than happy to answer any questions. I would rather have you call us, say, hey, how do we proceed in this case, than have a soldier wait for care or other things take place. I don't like to hear about the incident 2 or 3 weeks later. And that's typically what we're seeing. So we'd like to speed that process up. Bottom here at the G1, whoops, back one slide. The G1 Health Promotion Branch website, that will be your go-to guide. That's USART. Everything that they publish, all their new information that comes out, the INCAP briefing slides, anything that you'll need is in that SharePoint. So whatever you got to do to save that in your favorites. It has the 12301 orders process, WTU packet process. Everything can be found inside of that. Go ahead, next slide. So what is a line of duty? This is the process that documents a soldier's injury or illness, death, disease occurring during a duty status. So duty status is the key to this whole piece. That protects both the individual soldier and the government. We don't want to pick up soldiers existed prior to service type stuff, but we also want to cover them when they are in a duty status. Why is a line of duty important? The soldier receives adequate and timely medical care. Soldiers will receive benefits in a timely manner. Pay, whether it's immediate, could be a loss of, maybe they're not able to perform a civilian job, military job. Sorry if I'm not looking at both sides of the room. I didn't know how the exact layout was going to be, so I apologize to this side. And then timely access to the IDES process. Soldiers that are hurt in the line of duty and they start into the med board process need to have a line of duty. If they don't have a line of duty, then it will be processed as a PEB, possibly instead of an MEB. So that's kind of what initiates that process. So we need to make sure that we're documenting, taking care of these soldiers. Next slide, please. The module that we use, there's a hard copy form, which I've handed out. We'll go over in just a few minutes. And then everyone, how many UAs and commanders do I have? So a few of you, okay. A lot of this responsibility falls on you guys. And you're saying, okay, give me more, because I don't have enough to do. But TPU commanders and S1s, I would advise to designate a full-time staff that has signature authority to sign the 2173 and sign for you in the ELOD module. And the UA should have, all UA should have access to that module. If you don't, get with me please after. And please verify all your UICs and your down trace. Because you may have UICs that are missing, especially with the realignments that we've gone through, or you may have old ones that you need to get rid of. So get with me and we can get that taken care of. Then you're only allowed one user role. So if you as the UA also go in and sign for the commander, you can't have both. So that some other person will need to be designated to sign for the commander in that case. So as a UA, you may have signature authority for some actions. In this case, it can't. You can't cross over into those both. And then the user's social security number will change automatically. So, and those of you that were in the system prior to, you may be using your social security to log into the EMPS. Everyone else that's new, it assigns you a social security number or a quasi. And then the user should contact their supporting MSC or RSC system administrators for profile changes. So anything that's under the 807th will come up to our team. Anything that's at the RSC level, I can shoot an email up to them and they can make changes for you. Next slide. All right, I'm going to go ahead and look at their first page of their packet. It's a little 4-page. The 2173. This should be right next to your RST forms because everyone scrambles when some soldier gets taken to the emergency room or something happens. I would advise send two soldiers. One to take care of the admin portion and one to look after the soldier if you have the personnel to do so. But don't let holding up the personnel side of it hold up medical treatment for a soldier. First and foremost, let's get them taken care of. On section 1, if you look, there's two types. There's a formal and an informal. Informals will come up through unit, through brigade to the MSC. Formals will go through the brigade up to the RSC. So we follow the same standard procedures as far as through, to, and from. Then 1 through 5 is pretty much straightforward. Name, social security number, grade, organization. Be as specific, but give us as much information as you can on these. Date of injury, this is a big one. That must coincide with the date that they're on orders. And everything hinges on that date. So keep every document that you fill out prior and after will hinge on this date. So date of injury, that's key. Make sure that's, and then this, where the actual injury or disease or whatever took place. 6 through 18. This is what the provider is going to fill out. You can pre-fill as much of that if you know where they're going. Again, and then section 10, I don't know why for some reason, but we missed a lot of this, is the diagnosis. We need to have a clear-cut diagnosis. And unfortunately, pain is not a diagnosis. So I need to get more. If there's an ICD-9 code on those documents, those medical documents, put that in there. If they list a number of ICD-9 codes, put those in there. Yep. Next slide, please. Section 2. This is where the commander comes in. So the commanders, you guys are verifying duty status. Okay, 19, 20, 21, and then 22, 23, all good. 24 through 25 and 6 all pertain to injuries that resulted in death. The biggest thing that we see is I have signatures come up all the time. It's very vague details of what occurred, what happened, and then partial signatures. Or it's not, or it'll be someone else signing for the commander, but there's no memorandum. So if you have signature authority for the commander, please upload that into the module. I need to know that. All right, the next slide, please. Soldier's responsibility with respect to the line of duty. They're responsible for informing you that they're injured, hurt. This took place during a duty status. And then tell the admitting clerk, this is where that second person going to the hospital is key. Tell them to bill TRICARE. Because if not, they're going to bill the soldier. I'll talk later on about what we call a one-off or a MIMSO, worksheet 1. If possible, have the doctor, physician's assistant, nurse practitioner, or whomever fill in section 1 of the 2173. And then forward in the event that a lot of times you'll go to the emergency room, you may not get all the documents right then. You may have to follow up a couple days later. It may even require a 2870 release of medical information that the soldier fills out. Then you can go back to the clinic, get that medical documentation that we need. Worse, if you can't get the doctor to sign it at the emergency room, put the packet together, send it up to us, or we can send it up to the RSC, whether you pertain to the 63rd or the 88th, and we can get them to look it over and sign in that space. Or if you have a pad, a lot of you work at the cash level, you have TPU doctors, and if it's convenient or within a time frame, again, it's time sensitive. We don't want to wait till the next battle assembly to fill the paperwork out. If we've already got it, we can send it up. And if you're unable to obtain medical documents, that's the sign of the release. That's the 2870. Next slide. UA, register for the line of duty. Module, that's the EMMPS. We get audited on that. So your brigades and battalions will be coming down looking at that if you have that access. Ensure that the 2173 is sent to the soldier, with the soldier to treatment. Provide the commander a copy of this document so that he can verify. You're also going to provide him with a duty status, either a sign-in roster, something stating the type of duty that the soldier was in. Next slide, please. The priority, ensure the soldier gets medical care, and then again, don't hold up medical care for paperwork. Next slide, please. When to do a line of duty, okay? There's except injuries so slight to be clearly of not of lasting significance, or someone falls down during the APFT, scrapes, bruises, cuts. Take them to the hospital, get them taken care of, but they may not require any follow-up care. And then usually the typical rule of thumb is if the line of duty or the injury requires a profile, and it's probably going to be of lasting significance. So send them with a 2173, even though we may not use it. At least you've got it. Then you don't have to go back and recreate that document. Send them to get help, get care, bring the 2173 back, hold on to it. They need follow-up and further care, then we've got the process to start the line of duty. Go ahead, next slide. And then again, simple, no line of duty needed for minor things. Give you a chance to look that over. And these slides are available too on the disc. So if you have any references, I know I'm going through them kind of quick, but I'm going to get onto more of the meat and gravy of stuff. Next slide. Okay, our informal and our formal. The real difference is active duty 30 days when does not involve any criteria for formal. Okay, so the falls, the cuts, the broken legs, the simple things, the cut and dry, those are pretty easy to define. Where we get into a little bit of gray area is when there's strange or unusual circumstances. Okay, that's going to require a formal. We're going to have to appoint an investigating officer. We're going to look into the medical documents. Another thing too, if an event happens, get a couple sworn statements. Hey, did you see what happened here? Have them jot that down right after the event. That's substantial in a lot of things that take place. Right now we're working a lot of line of duties that are years old, 2007, 2010, 2012. Oh, thank you, sir. I like to walk around, so I've been confined to this space, so I apologize. I'll just point rather than walking over there. Anything that involves a traveling to, this is another big one we get, in a duty status. So if soldier is reporting to duty on lodging in kind, he's staying overnight. If he's en route, he or she is en route on Friday evening, reporting to duty, they're driving directly to duty, they are in a duty status. Okay, they are in the act of coming to perform drill. So we do have, and anything that involves a motor vehicle is going to be a formal. Big thing we need to do is get police reports and all documentation on that. So here we have motor vehicle accidents. Or if, like, next of kin in the event of say the service member passes on or is incapacitated, and the next of kin, hey, I need a, they're requesting an investigation. Next slide. Informal. These are the required documents to be uploaded. Your hard copy of the 2173, your whatever duty status, whether that's a 1380 if they're RSTing, whether that's a signed-in roster, if they're on ADT, ADTS, whatever duty status. And please, if there's multiple social security numbers on that sign-in roster, please black those out. Again, it's PII. We don't need to, all I need to see is that soldier's duty status, commander's signature preferably, and everything else can be blocked out. Next slide. Formal. This requires a bit more. You're going to have a 2173. The DD 261 is your findings from the investigating officer. At the MSC level, we'll appoint the investigating officer. So you'll just follow through the procedures as if you were doing an informal, but we'll actually appoint the investigating officer and get the appointment memos and everything else done. We'll follow up on that. Medical documents. This is the big key. I don't need a sick call slip. That doesn't tell me anything. What I need is those notes the doctor actually wrote. Prescriptions sometimes, I've seen bills, different things. They can be loaded in the additional portion or additional files on the EMMPS module. But I need the stuff that shows an impression, a diagnosis, the meat and gravy of the, well, that's not a very good term to use, but bear with me. Sketches, maps, was the soldier driving directly home? Did they follow the same route or did they deviate? Those things are important in that investigation. Next slide, please. And this is really what constitutes our medical documentation, what we're looking for. This is a big thing too, MRIs and CAT scans. We don't necessarily need the images. I'm not a professional. I can't throw up your x-rays and tell you what's going on. But what I need is the impression. What the technician or the doctor that viewed those results found, what their findings were. And again, instruct your soldiers that you're trying to help them. I mean, they sometimes get frustrated with the process because it can take time. It can go very smooth and it can go very quickly if everyone's on board and we're tracking. And call us. Again, if you have questions, hey, what's taking so long on this? Most of our delinquent line of duties right now are sitting at the UA in draft status or at the commander level because the commander doesn't even know he has a line of duty sitting there that he needs to sign. And then it's hard as TPU commanders. That's why I would advise pass down to the, yes sir?
Doesn't the commander get some type of email notification that he needs to go in and sign something?
He does, but a lot of it comes in as an email. A lot of people have a rule set up and it just forwards to a box. I mean, you should get a notification on every movement within that module. That's correct. Again, my advice would be dedicate a full-time, not TPU, AGR, with that permission. Obviously, inform the commander, hey, this is what we're looking at, sir. But that's where 90% of our delays occur, is at the draft status, waiting for documents. Again, if you don't have all the documents, don't start putting it into the module. Start a hard copy file. Obviously protect that information, the PII, the HIPAA, but get all the documents you need. Then once you've received all those documents, then upload it into the module. Because then the clock starts when you guys put that first document in there. And we realistically we're supposed to complete informals in 30 days and formals within 70. But that includes the time at the RSC level and every step in between. Next slide. An approved LOD actually consists of the 2173 and a memorandum. On informals, they can be approved at the MSC level, the OFTS command level. Formals actually will go to the RSC for approval. So the 2173, the findings from the investigating officer, all the appointing memorandums, and the investigating officer's findings will then be forwarded to the RSC, who vets it through JAG, through their surgeon cell, and then they make a decision. And again, the more evidence we can collect and find showing the diagnosis, that's the supporting documents we need. Informals can't be considered not in the line of duty. We do a lot of admin closures because we don't have any supporting medical documents. I can only let it sit in that draft status for so long, and then we have to close it. If I don't have a diagnosis or if I'm missing, if you have a soldier that's being maybe a little bit stubborn, doesn't want to bring in the documents, sit down, do a counseling with them. I've got some 4856s that are already pre-filled. If anyone needs those, just send me an email. We can send them out. Sit down with them, explain that you're trying to help them. Say, hey, by next drill, can you please bring in your documents that we need to complete this line of duty for you. That does two things. It shows that you're taking the initiative, and in the event that they're dissatisfied with the outcome, well, you've counseled them. You've done all you can do to provide them with information and get information for them. Next slide. Suicidal and ideations in line of duties. If a soldier is suicidal or homicidal, you should direct them to care immediately, and they should be in a duty status. Again, if a soldier or service member is injured in a drill status or whatever duty status, and their orders are about to end and they're still hospitalized, please get in touch with my team so that we can get orders to cover them during their length of stay, because they need to be in an order in a duty status if they are hospitalized. Next slide. Dental line of duties. These are a bit more complicated. My advice is, if it's an emergency type dental situation, to contact United Concordia directly and find out what they need, because they're going to wait until the actual line of duty is completed before they're going to approve anything. But if it's an emergency situation, we need to get in touch with them as soon as possible. They also have a PDF here. That link works on your disk. Next slide, please. One-off medical. So go ahead and turn to page 2. It's on the back side of 2173. This is the medical eligibility for the reserve component. It used to be called MIMSO Form 1, Worksheet 1, and now it's DHA Great Lakes. They keep changing their name, so they still refer to themselves as MIMSO, but it's definitely DHA Great Lakes. This form is for what we call a medical one-off. So a soldier gets hurt, not of lasting significance, the bill needs to get paid. We fill this out, and again, it's pretty straightforward, and be as specific as we can. Especially like line 11, diagnosis, the ICD-9 code, type of orders, and you'll have to put a copy of those orders where it's a weekend drill, sign-in roster. Send that up. They prefer fax. I'm sure it scans and goes to somebody's email box, but we're the 21st century, and here we are. I would advise, as soon as you fax that up, to call them. I'll have that number later on in the slide deck, but call and follow up. Make sure they receive that. And then it usually only takes them 1 to 2 days at the most to receive that, then follow up. And you may have to call back over to the clinic or the treatment facility where the soldier was treated and say, hey, have you guys billed TRICARE? And it's electronic, so DHA Great Lakes can actually go in and see the bills and then pull them. But it has to be directed towards TRICARE. If not, you're going to get a soldier that's going to continually get billed, and he's going to get frustrated. He's hurt. He doesn't need bills piling up. So there's a couple of examples. They twisted an ankle, sent to the medical provider. They're diagnosed with a sprained ankle. They had X-rays, doesn't show any broken bones. They give us some Motrin. They're not hurt. They're a little banged up. They just need the medical bill taken care of. The soldier doesn't feel well. They're sent to the provider, diagnosed with a common cold. They're released with over-the-counter medications, and they just follow up with treatment on their own. Again, we just need to get the initial visit taken care of. Next slide, please. So the soldier lives more than 50 miles. This is kind of the processing that DHA Great Lakes uses. Here's a link. This link does work, and this link actually goes to their guide. It's about 19 pages, I think, and it has all the forms for requests for follow-up care, for surgery, or that may be needed for that soldier. That's all explained in their guide too. Next slide, please. This just, again, walks us through what's required on the form. Next slide. And this is what's required when we fax it up. Or you can mail it in. I would advise, again, fax. But if in the event that you do want to send it by mail, there's the option. Next slide, please. This is for follow-up for worksheet 2 and 6 for surgery. So they're going to need the 2173, the supporting medical documents showing the plan of care or action, what follow-up visits they need. They're going to need to jump into the module. Now at this point, you're going to start the LOD process as well and send that up through MIMSO in the module, or you can request it, fax it in, and call them for follow-up care. I think everybody's lunch is settling in nice. I see some droopy eyes and grumbly. Next slide. So this is Mr. Jones. He is probably one of the better POCs at the MIMSO. I want to say he's a GS 14 or 15 up there. So if you have concerns, questions, you're not getting the answers you need from those folks when you call up, shoot him an email or give him a call. He's at this extension. Here's the number you can call to confirm with DHA Great Lakes that they did receive that form on follow-up care. Next slide. Here's our other things to consider. ADOS RC. I spoke a little bit about this when Sergeant Larson was addressing ADOS RC. We don't send it up for the PII, but probably the easiest thing to do is send an email. If you haven't heard a response from us fairly quickly, give us a call. We deal with a lot of emails and a lot of cases, but if you can get a call into us, normally one of us will respond within a couple hours to get those orders, especially if a service member is injured, they're in the hospital, they're in an inpatient, we need to get them on orders. I mean, flat out, no questions. INCAP's another option, and then WTU. If you don't have a copy of this op order, that G1 Health Promotions branch through USARC it spells out everything. It gives you the memorandums, the process to follow. Next slide, please. So this is an explanation of when we would use the ADOS RC for medical. So they're injured during AT, BA, ADSW orders other than a MOB. They require follow-on care and may need placement in WTU. This is another issue we're running into with soldiers that are not MOS-Q'd. So you have a split op that has not completed their MOS training. They're not eligible to go to a WTU. So maybe just they're in the process of rewriting and working this part of the regulation, but as of right now, if they get injured and they're not MOS-Q'd, we can't get them into a WTU. It's more difficult. I mean, then we can always ask for an exception to policy. So maybe just keep that in mind as you're doing your activities. Maybe limit the exposure. I mean, I don't know how else to help. It's kind of a gray area. I mean, the majority of the time they do approve those packets because we ask them for an exception to policy. But just keep that in mind that that's one of the events and things we've been noticing. Up to 30 days, Mr. Taylor mentioned that. We at first made the mistake of giving, not mistake, we gave them the whole enchilada per se, and they would take it and then not do it, not follow up on the stuff that they're supposed to do. So it's mostly to bridge a gap. This would be really in a case of a soldier that's injured quite severely, needs to get into a WTU, and while we're working the WTU packet, this is our interim fix. If we have to go beyond the initial 60 days, that has to go up to USARC. It can be done. It just takes a little bit of time and funding come back down from them. But we've had this happen in a couple instances where they didn't quite qualify to go into the WTU, but they needed follow-on medical care, so they stayed on ADOS orders for 30 or 60 days. And that was funded through USARC. Also, I spoke a little bit earlier too, if you've got a medical or dental appointment these soldiers need to go to, we can cut 1 and 2 day orders or whatever needs be. Again, keep in mind that any travel falls on the unit. So I can get you orders, or we can get orders cut, but you got to cover the travel costs, the DTS portion. We can approve up to 30 days at our level. Any extension or anything beyond that goes up to G1. Next slide. This is going to give us a breakdown of what we need to send it up to USARC. My advice is that when you first ask for that first 30 days or time in there, that you start this justification memo, the RFO, the PQR so we can pull the ETS, MRD dates, funding, we'll take care of that. Appointment schedule for the medical appointments, what they require, and then a UMR printout, especially if we're going to request beyond a 30-day period. Next slide. This is a voluntary program that places soldiers on temporary active duty, and then normally they're transitioned into a WTU for follow-on care. Some of them will actually enter into the IDES now. It's an older slide, so it's got PDES, but IDES process, or they may go through the med board process or the PEB process. Next slide.
What does AD
ADME is active duty for medical. There we go. Too many acronyms. Okay, so the INCAP, this is going to be our next 4 or 5 handouts. References 135, 381, and then there's these 2 DOTIs. Go ahead, next slide. This is compensation for an injury that occurred in the line of duty. So in order for INCAP to be processed, they have to have gone through the whole line of duty process, received a 2173 with a memorandum. So that's why it's important that we start that process early, especially if the soldier cannot complete work. Another thing with INCAP pay is they have to have incurred the loss. So you've got to have gone through a period where you're not working, not receiving an income in order to make that claim. It's kind of referred to loosely as the workman's comp for the reserve, or for the next slide, please. So this is submitted through, my pointer died. But this is submitted through the E-line of duty, through the MedChart. We're back. They're working on the ability, sometimes we can send stuff up straight to the RSC and we can digitally sign everything, but most likely you're going to be dealing with a civilian or some provider that can't digitally sign or CAC sign. So you're going to have to print these documents out. I would do as much as you can digitally and then start signing after that, for legibility purposes more than anything. Not that we don't have great handwriting in the Army, right? UAs, personnel sergeants, and commanders must use the module. Everything has to go up through that. The Guard started that process in 2009. We're a little later on getting into it, and they have to have their line of duty in the line of duty module. Next slide. There's 2 tiers. Tier 1 is they're not able to perform military duty to include civilian duty. Tier 1 is basically if they meet the 507 requirements on that profile, that's what dictates which tier they're going to fall under. The majority of the soldiers will fall under a Tier 1. I know there's been some confusion kind of in the past on that, and they are authorized up to full military pay and allowances minus gross civilian income or any VA compensation. Next slide. Tier 2 is they're able to perform military duty, but they're not able to perform a civilian job. And the soldier must be employed in this circumstance. Next slide. They need to turn in all their medical documentation to the UA where they're using an RPAC. I would advise if you're using an RPAC to document who you're taking it over to, when you took it over to them, and then do a follow-up. You got to stay on them. I mean, they're there to help us out, but in the same sense, it kind of hinders us in ways too. They do a great job usually if we work together as a team, right? One fight. The forms. There's 3 forms involved in this process. Go ahead and look at that smaller packet that was handed out. 75, 74. Have this soldier fill this out. Fill in as much as you can for them. Month of year claim, and you can't go into other months on this form. So I'm speaking in particular with respect to 11 Alpha and 11 Bravo. So it's mid-month. So it's that's like we're here in April. So it's April 14th. Soldiers injured today. So April 14th through the end of April. That's one period, one form. So you have to have it for every 30-day period. You have to have a separate 75, 74. You can't just throw 90 days or 60 days or 6 months. Then have them fill that out for each form. They're going to have to put their employer information on it. The soldier's going to have to sign it, then take it into that employer to verify income. Then it comes back. The commander has to look at it. The soldier signs it in front of the commander typically. The commander is going to verify if there is an approved line of duty. And that has to be done for each period. Which leads us into, on the 3rd page, that page 3 of 3, which is actually page 4 in your start of page 3 on your handout. It kind of walks you through those forms. But I would advise whatever you want to do to make your notes, but 11A and 11B are kind of where we usually fall into most of our problems for that 30-day period. So if it's a partial month, again, it's next form in question is the 7574-1. Next slide, please. On the 7574-1, this is the physician. This is their findings. So they're going to either see the soldier or they're going to review their documents. I'm looking at section block 8. And they're going to make their determination that they are fit to perform military duties or they're not fit. That's going to determine your tier 1 and your tier 2. And the same thing for the incapacitation on the civilian job. Are they able to perform military duties but not able to perform civilian duties? One thing you're going to have to include on tier 2 claims is we need a job description. And typically it has to be on letterhead from the employer. It's a duty, what their duties are, what their requirements are. And then we need all their financial documents, W-2s, in order to prove income. Another problem we run into is if we see spikes in income. Last year said this person made, $35,000. This year they're making 100. Well, yeah, they don't like discrepancies from month to month. And if the numbers don't add up, they're going to catch it at the RSC level and say, why did the soldier make $3,000 this month and $7,000 this month? Our last form, and this will cover, it's on the very last page on the back. This will go up with each set of incapacitation pay. So for each period, whether you do 90 days, however many months, you'll have the soldier fill out the top portion, read through, make sure they understand these. This is a legally binding contract, and they will go back and collect if there's any type of false claims made. Have the soldier sign that in front of the commander or person that's authorized to sign for the commander, and that gets scanned up into the module. Self-employed, again, they need to provide a lot more, tax documents. The more information we can get to support the claim, the better off we are. If there's a lot of holes, a lot of discrepancies, that's where questions come in. Then they have to report any type of VA compensation that they are receiving. That will be deducted from any type of INCAP pay. Next slide. This is the treating physician. Again, if you're having issues with the civilian providers not signing that, send us the forms. We can send it up to the RSC, have the surgeon cell take a look at it, see if they'll authorize it. And then you can do 3 months at a time. So you'll have to do the -1 for every 3-month period. So you may only have a partial month and then 2 fulls. That counts as your 3-month period. Next slide, please. Recovery care coordinators. These are established at the RSC level. They're usually contracted personnel that are there to help the soldier out. They can not only provide them with support through the med board, the PEB process, but they can also help out with line of duty investigations. They can help out with INCAP pay. They typically work right there in the same office usually. I know Mr. Vole at the 88th, he can go over and talk to the different people in the different areas and say, hey, what's the holdup? And he has that push. He is definitely an advocate. He or she, the recovery care coordinator, is an advocate for the soldier. There's ADME orders that can help with those packets. They're familiar with all these processes. Next slide. They can also help out with financial aid. They have access to a lot of non-profits, a lot of stuff within the community where they can point or help soldiers find employment, housing, spiritual support, counseling. So they're definitely a great asset. They can help them through with the TRICARE as well as VA, navigating some of those things, provide a lot of family support. Next slide, please. So as far as these are the different areas. You probably won't be able to see this from there, but here's Fort Hood's contact information. So there's some of you that are in the 63rd, and there's others that are in the 88th. As far as the 88th, Mr. Vole is right here. But that's also in your slide deck, if you can't see that. Next slide. Here's our point of contacts, myself, Captain Towson, and Sergeant Gonzalez.